Good afternoon, everyone, and welcome. It's exactly 12 noon. Thank you for joining us for today's webinar, TB Meningitis, a Diagnosis Not to Miss. I'm Angelito Bravo, Program Manager for Pulmonary Disease Services with Orange County Healthcare Agency, also known as the TB Control and Prevention Program. We're fortunate to be joined by a distinguished expert in the field, Dr. Helene Calvé, who brings a wealth of experience in infectious disease and TB control. Before we begin, just a few quick reminders. An evaluation survey will be emailed to you a few days after the webinar, and this will be sent to the email address that you used to register. Please note that the survey link will only be active for 48 hours and cannot be forwarded. Once you complete the survey, you'll receive a separate link to click to claim your CME or CE credits electronically. A few housekeeping items to keep in mind. All participants will remain muted during the presentation to minimize background noise. If you have a question, you're more than welcome to raise your hand to be unmuted or simply type your question into the chat box at any time. This session is being recorded, and a link to the recording will be emailed to you, to all attendees after the event. Now, it's my pleasure to introduce our speaker, Dr. Helene Calvé. Dr. Calvé earned her medical degree from UCLA and is board certified in both internal medicine and infectious diseases. She has dedicated nearly 25 years to public health, serving in key leadership roles, including health officer and TB controller in Long Beach, and later as deputy health officer here in Orange County. During the COVID-19 pandemic, she led response efforts in long-term care facilities, and since 2022, she has returned her focus to TB control in both Orange County and Long Beach. As of September 2024, she serves as TB controller and medical director of pulmonary disease services here in Orange County, while continuing to provide care for TB patients in Long Beach. Her deep expertise and commitment to community health makes her an invaluable voice in today's discussion. Please join me in welcoming Dr. Helene Calvé.
Thank you for that kind introduction, Angelito. All right, for about the next, let me get my, can you stop sharing your screen? I need to share mine, right?
Yes, go ahead.
Okay, so, okay, back to the beginning. Sorry, I should have had this ready to go. Okay, so thanks for the introduction. Thank you all for joining us during your lunch hour.
Dr. Calvé, can
I
you
know.
switch screens?
I know I need to.
Display settings?
Hang on a second. Let me. Yeah, I can't see that when it's up there. There we go. Now I can't share the screen. All right, hold on a second. Okay. Sorry. Screen. I'm not sure. Just need to get this thing out of the way. There we go. Okay, sorry about that. All right, yeah, so thanks for spending your lunch hour with us. For the next about 50 minutes, I'll be talking about TB meningitis. So why should you listen to this lecture, aside from the fact that TB meningitis is a very important illness? In Orange County, between November 2024 and April 2025, we actually had 4 people who died of TB meningitis without leaving the hospital. This was 4 different hospitals, 4 different groups of providers. And so I thought the best way to kind of reach out is to do a webinar just to educate everyone. So this is focused kind of on Orange County. I realize we have people from other local jurisdictions here. They're more than welcome. So I'm hoping that this information will help you recognize the diagnosis sooner and start treatment early to help to prevent morbidity and mortality. So by the end of the lecture, I hope that you will be able to identify patient groups at epidemiologic risk for TB, recognize the clinical, radiographic, and laboratory findings suggestive of TB meningitis, discuss the limitations of diagnostic tools used for TB meningitis, and then list the medications recommended in the intensified regimen. So before I get started, just a few acknowledgments. Despite what Angelito said, I really am not an expert in TB meningitis. And my first 11 years in TB control, I did treat a handful of cases. For the most part, they did well. I think one person who had MDS died. But it wasn't until I came back into TB control 3.5 years ago that I realized how little I knew. So this talk is dedicated to JA. So JA is a young developmentally disabled woman who I treated at Long Beach, and she initially had POTS disease, which was unrecognized, and in time it spread to her brain. She was very, very ill in the hospital. I didn't think she was going to come out of the hospital alive, but she actually did. And her first visit with me as an outpatient after about 2 months in the hospital, she looked relatively well. She made me this little bracelet. But unfortunately, over the coming months, she started losing weight, complaining of more back pain. She had neurologic decline. I involved some experts to advise me on this, and it was a tough battle for JA. Unfortunately, she spent the last 8 months of her life in hospitals, and eventually expired of sepsis and an LTAC. So she's one of those patients, we all have those patients we'll never forget, and she's one I'll never forget. And I'm eternally grateful to Dr. Caitlin Reed, who is now with Seattle-King County TB Control, formerly of the CDC, to Dr. Felicia Chow, who's an ID neurology specialist at UCSF, and all the consultants at California Department of Public Health, who taught me so much about TB meningitis during the management of this case. So the purpose of this lecture is not to blame, not to shame anyone. I'm acknowledging that this is a tough disease to diagnose and a tough disease to treat. So hopefully you'll get some pearls from this lecture. So I'm going to go over the epidemiology of TB in California and Orange County, have some diagnostic tips interspersed during the talk about the tools for diagnosis of TB meningitis and their limitations, cover the intensified treatment that's recommended, including which drugs and the dosing, and then finish up with reporting. I have no financial disclosures. So TB in California is pretty much stuck at 2,100 cases per year. So every jurisdiction saw a decrease during the pandemic when folks were really not coming in for care, and then had a rebound afterwards. But there's really been no substantial decline in at least a dozen years, if not more than that. In Orange County, we see a similar picture, a little bit more variability, maybe not quite as straight as the state, but yes, we had a decline during the pandemic that rebounded up to actually our highest numbers in about 15 years in 2023, came back down in 2024, but 2025 is looking like even higher than 2023. So really not driving cases down. If we were to draw a line here, it'd be around 170 cases. And important to realize that TB mortality is not insubstantial. About 13% of our cases expire. And recent data just discussed by the state or presented by the state is that it's 14% statewide. So not a minimal illness. So in the state, folks who get TB come from many different countries. So about 16% are born in the US, the remainder from other countries, the proportion of their contribution indicated by the size of the square. So Mexico being number one, 22%, followed by Philippines, Vietnam, China, and India, each with 6%, and then a whole smattering of other countries with smaller percentages of TB cases. In Orange County, our percentage is even higher. 91% of our TB cases are born outside the US, and nearly 80% of them come from 3 general areas/regions. So we have a very large Vietnamese population in Orange County. So Vietnamese people account for about almost 40% of our cases. Another 20, almost 25 are Hispanic, mainly from Mexico. 15% from the Philippines, and then lower percentages from other areas. So again, about 2/3, almost 2/3 of our cases are Asian, about 1/3 Hispanic, fewer white and African American. But the other thing that kind of stands out is the age of the cases. So almost half of our cases, 47%, are 65 or older. I tend to joke that we're running a geriatric TB clinic, but it's kind of true. And folks who are in their 70s, 80s, and even 90s are really, really hard to treat for TB. They often have multiple comorbidities or on a ton of medicines. some of which may interact, have a lot of side effects, and are very poorly tolerant to the medication. So they don't do well in general. So why are we seeing it so much in older individuals? Well, those of you who may remember years ago, we used to focus on the recent arrivers. I don't know if any of you remember, the recommendations used to be that we should test anyone who immigrated the country within 5 years for TB. And yes, we do see a lot of TB in folks in the first year when they come in. Now, some of this big spike here in the first year may be due to the screening that we do in TB control of legal immigrants who get tested for TB in their country of origin and often retested here. But that number comes down pretty quickly. And if we just focused on those first 5 years, we would miss almost 80% of those at risk for having TB. So almost 80% have been in the US 5 or more years, and 50% have been in the US 20 or more years. Look at these, even going out to 60 years. So we can no longer think of only recent immigrants being at risk for TB. Anyone who is born in a country with high prevalence is at risk for the remainder of their life. They may be very acculturated, they may speak English. You may not think of them as an immigrant, but if they're born in a country with high TB prevalence, they should be tested. And there is a new California law that is promoting that in primary care settings, that people born in countries of high prevalence, regardless of their age or when they came to this country, should be screened for TB. So not surprising then to find that the case rates actually go up with age. As people get older, they have more comorbidities, their immune system's weaker, and we see a male predominance in almost every age range except for the teenagers and older children. So when we compare the non-US born with the US born patients, we see some differences. So age, definitely. The non-US born or foreign born are typically older. We see very few cases in children versus US born. It's more of a bell-shaped curve with a peak being around 25 to 44. And we also see some difference in some of the risk factors. Specifically, HIV is more common in the US born. Excessive alcohol use or any substance use, all of these are much more common in the US born. Homelessness, either currently or ever, is much more common in the US born as in incarceration. So really two kind of different groups. US born have the higher social risk factors and are generally younger. Another common thing in our TB patients is they often have medical comorbidities, and diabetes is one of the most common one. This is kind of dated information, but I haven't seen it updated lately. So nearly a third of the patients have diabetes, and diabetes out of control, or any diabetes, and certainly that out of control, is going to increase the risk that if that person has LTBI, that it may become active. End-stage renal disease and HIV are other really strong risk factors for developing active TB, especially HIV is probably the strongest. Fortunately, there's not high percentages of those among our cases, but we're seeing a lot of other immunosuppressive conditions and use of not only TNF-alpha antagonist therapies, but all kind of biologics that increase the risk that if this person has LTBI, they may develop TB disease. And then, of course, organ transplant. So some key points is that the TB cases are really not decreasing because we're not getting to that big population that's latently infected and just kind of waiting to reactivate. TB disease in California is seen predominantly in foreign-born and older population, many of whom have been in the country for many years and often have multiple medical comorbidities, versus the US born with TB disease are mostly younger and have different risk factors, and the mortality rate is significant. So definitely think TB in older foreign-born patients with clinical syndromes suggestive of TB. Since TB affects pretty much all races and genders, we want to make sure we're providing equitable care, using inclusive language when we're discussing disease and treatment, and providing cultural appropriate education, and being aware of the disparities and socioeconomic risk factors that lead to TB, and helping to address these with resources. So there's many tools in the toolbox for TB disease, but the problem is none of them are perfect. And so TB is still not an easy diagnosis to make in many cases. So I'm going to talk about some of these tools. These are not all directly related to TB meningitis, but many of them may be done as part of the evaluation. So remember that since all these laboratory tools are not perfect, sometimes your clinical suspicion or intuition about TB may be the most important tool you have. So sensitivity of sputum smears and NATs. It's estimated that 30 to 60% of pulmonary TB may be smear negative. Now, good sputum induction can improve that yield. I can't tell you the number of times we've seen patients discharged from the hospital with quote unquote negative smears. We bring them into clinic, do a good induced sputum, and they're 1 or 2 plus. So if patients are not like actively expectorating a lot, please order induced sputums. Gnats are more sensitive and can help to identify TB a lot sooner than cultures. So a positive TB gnat in a smear positive or negative specimen is really a diagnosis of TB. But the problem is the gnats are not so helpful in smear negative cases. Sensitivity ranges from 28 to 72%. Don't really believe the 72%. I think it's closer to 28% because I've seen many smear negative, gnat negative time 2 end up growing TB. And usually it takes a while because it's few organisms. So it may turn up positive in 6 to 7 weeks. So just be aware those negative smears and gnats does not rule out TB. And if your suspicion is high, you should still start therapy in these cases. So please don't write that in the chart. I've seen that written many times. And part of my job as a TB controller is to review the charts of all suspect or confirmed TB cases in the county. So now we have our comparison of IGRA, our newer immunologic test to see if our immune system has seen TB versus the TST, which has been around a long time. And there's pluses and minuses to both of those. So just let me go through those really quickly. IGRA is TB specific. It does not cross-react with BCG. That's helpful, especially for your patients who say, oh, my test is positive because I had BCG. It controls for low immune response. So we get 4 numbers. We get a TB1 reaction, a TB2 reaction, a mitogen, which is a non-specific lymphocyte stimulant. So if your lymphocytes are working, the mitogen should be very high. It should be around 10 or at least 5 or more. I always get suspicious when they're really low. Versus a TST. So if that's very low, we're going to get an indeterminate. Versus a TST, if you don't react, you don't know if it's because a person really doesn't have TB infection, or because their immune system is just not working, or because the TB skin test was not placed or read well. So at least this gives us more information. For those of us working in outpatient settings, resulting with 1 patient visit is really helpful because a lot of patients don't come back for their TST reads. And also importantly, there's minimal inter-reader variability. With a skin test, it's hard to kind of feel and measure at the same time. If there's some induration, you may have 3 different people feel it, look at it, and come up with 3 different numbers versus here we get standard numbers. So that, in my mind, those are all good things. But one significant downside is it's one standard for all. So recall that the interpretation of the TST depends on the patient population. There's different cut points. So 5 millimeters considered positive and HIV positive, or people who have significant immunosuppression, also considered positive in recent contacts of a TB case, or in those who have fibrotic changes on the chest X-ray consistent with old TB. And I would throw in that group also TB suspect, someone who you suspect may be sick with TB. Likelihood is their immune system's not reacting very well to the bug, so you may see lower levels of reaction to those TB antigens. And then it's 10 millimeters for everyone else. But the quantiferon gold, and I don't want to see like I'm favoring quantiferon gold, it's just the one that the IGRA that we use much more commonly, has just 1 cut point, 0.35. The T-spot does have this, what's called a borderline result. I think it's 4 to 7 spots is considered borderline, and then they have a negative and positive. But many have suggested there should be a lower cut point for some higher risk groups, and I absolutely agree with that, 120%. And there's some data to kind of support that. So this one study, which was not published, but was presented in a scientific conference, the researchers looked at 414 close contacts to TB. So those are people who a 5 millimeter skin test would be positive. And they did both TST and quantiferon gold. And they found that a cut point of 0.26 was a one that captured those, or higher, was a one that was sort of equivalent to a 5 millimeter skin test. And then another study done kind of looked at patients, a whole broad range of patients that had IGRA, and kind of broke them down into quartiles as being a high positive, low positive, a borderline, which they said of 0.15 to 0.34. And they felt that that borderline zone seemed to represent true TB antigen responses. There was a gradient of increasing prevalence of risk factors and indicators, and with a nearly identical findings in patients with borderline or low positive results. So I encourage you to always look at the quantitative values of IGRA, consider it in the patient context, knowing that there's not different breakpoints. You may see lower levels of reactivity to TB antigens in people who are really sick with TB or have isolated areas of TB involvement. And just remember, the bottom line is a negative IgRA or TST does not rule out TB disease. So in a TB suspect, if you send an IgRA, and some people don't because it's not, if it's positive, it's helpful. If it's negative, it's not, it's not that helpful. But if you send it and you see intermediate reactivity, that would increase my suspicion. But you should not be dissuaded by completely negative IgRA with 0 responses to the TB antigens. Okay, so body fluid analysis. I'm just going to go through this quickly. Neither one of these are really related to TB meningitis, but they're both important, and there's some common themes between those. So peritoneal fluid in case of abdominal TB and pleural fluid, really the yield of AFB in the fluid is very, very low. The chance of getting a smear positive is 5 to 10%. Culture positives maybe around 20%. So we rely on all these other tests that we send, the protein, glucose, the LDH, ADA, the cell count and diff, those kind of things are where we may kind of be more suspicious for TB. And I have the typical findings here, but usually it's higher protein with some high white cells or highish white cells, usually with a lymphocytic predominance. But if that's still not definitive, you can always go for tissue. You can biopsy the pleura or do a laparoscopic biopsy. It's very helpful. You can see granulomatous changes and has a much higher yield on culture. Remember, though, that if you ever suspect extrapulmonary TB, you always want to check the sputum too, even if the chest X-ray is normal. If you get it on sputum, then you don't have to go for these biopsies. Okay, so the first case, I'm going to be presenting each of these 4 cases. A 62-year-old man admitted to the hospital in October of last year with altered mental status. He, on admission, the MRI showed leptomeningeal enhancement with bilateral thalamic strokes. LP showed a very low glucose, high protein, white cells of 145 with a lymphocytic predominance, but AFB smear and PCR were negative. His IgRA also completely negative, no response at all to the TB antigens and a good mitogen. He was started on antimicrobials, but had progressive bilateral brainstem strokes, presumed to be a vasculitis, and had a meningeal biopsy, but that was not consistent with vasculitis. But the diagnosis was primary angiitis of CNS, treated with prednisone, and sent to a SNF. So within just 6 days, he was sent back to the hospital from the SNF for unresponsiveness, and the MRI showed new strokes. Then several days after, the CSF culture from that 810 tap was identified as growing MTB, and medications were started, but unfortunately, the patient expired about 6 weeks later. So some teaching points here. This is an elderly immigrant. Epidemiologic risk for TB, think TB. IgRA negative does not rule out TB disease. This person had some pretty suggestive findings on the imaging and the CSF. So leptomeningeal enhancement on MRI is a common finding with TB meningitis. The CSF with very low glucose, high protein, white cells elevated with a lymphocytic differential, but note that in early disease, it can be neutrophilic, and stroke suggestive of vasculitis, which is very common in TBM. So don't let those negative tests dissuade your thinking. So that brings me to the last body fluid, and in the case of this lecture, the most important, CSF. So like pleural fluid and peritoneal fluid, AFB smear sensitivity is very low, like 8%. Gene expert may be a little bit better, 40%. I think that may be a little bit high as well, but definitely we do see that popping up positive more than the smears. The sensitivity of both AFB smear and NAT can be increased by using high volume specimens and doing multiple specimens, or asking your microbiologist to spend 30 minutes looking at it, but no clinical microbiologist is going to have time to spend 30 minutes on one specimen. So we don't normally do meningeal biopsies. So we have to, like we might do pleural biopsies or omental biopsies. So we got to look at those CSF parameters, right? So it's usually less than 45 on the glucose. And as you saw in this case, 10. So getting down to the 10 and 20, got to have TB on your differential. High protein, elevated WBCs, usually between 100 and 500 with normally a lymphocytic predominance, but early in disease, you can see fewer cells with a poly predominance. Now, one tip here is that not all CSF is the same. If the inflammation is in the basilar meninges, fluid from a ventriculostomy or an external ventricular drain may not reflect what's going on below. Remember that the CSF is created in the choroid plexus in the ventricles kind of circulates up and around. So if you're sampling from kind of high in those lateral ventricles and all the action is in the base of the brain, you got to go where the money is because the fluids can look very different. So in regards for imaging for TB meningitis, MRI with contrast is the best. CT has very limited usefulness, and I'm going to have some examples of that in these following cases. But realize that early in disease, 15% may have a normal MRI. Again, don't be misled by normal findings. The classic findings are basilar meningitis or basilar meninges with inflammation or exudate. You can see hydrocephalus if it's more of a cerebritis picture. Infarcts of the basal ganglia, thalamus, brainstem, cortex, also common due to vasculitis, and you may see abscesses or tuberculomas. So think TB meningitis in a person who's at epidemiologic risk, has the classic imaging, suggestive CSF parameters, regardless of what your IGRA, AFB smear, and NAT results are. So here's an example of an axial T1 with contrast, showing all that inflammatory changes around the base of the brain, predominantly in the basal cisterns. So clinical presentations can vary. You can have more meningeal symptoms or cerebritis symptoms with a headache, stiff neck, altered mental status. That may be subacute and wax and wane over several weeks to even months, or can be more acute with progression over several days to a week. Strokes are pretty common. Vasculitis is very common, TB meningitis. So consider TB for patients presenting with strokes who have evidence of an inflammatory component of the basilar meninges or suggestive CSF findings. And then since it involves the base of the brain where the cranial nerves exit, you can see cranial nerve abnormalities with TB meningitis. Other focal neurosigns in the absence of stroke or large tuberculomas, though, are somewhat unusual. Okay, so that brings us to case 2. This is a 68-year-old man, a Vietnamese man with diabetes, hypertension, history of a left pleural effusion 2 years ago, which was not evaluated, admitted in December of last year with cough for 2 years, chills, night sweats, weight loss for 1 month. He gave a related history of TB as a child, which was not adequately treated. He was febrile and tachycardic in the ER. Admission labs were suggestive for had significant for hyponatremia, which we do see not uncommonly in our TB patients, really sick ones. CT scan of the chest showed a moderate right and small left pleural effusion. He was started on antimicrobials. At that point, the ID notes said that they suspect TB, but the sputum for AFB were negative. The MTB PCR was negative. Pleural fluid tap was kind of bloody, so a lot of red blood cells, but actually proportionally still high white blood cells, 94% lymphs. The glucose was not particularly low, the protein was high, and the ADA was really kind of in the normal range, and AFB smear negative. I'm not sure if a PCR was done on that. Again, like our prior case, IGRA came back completely negative, 0, 0, mitogen decent, and HIV negative. So that was 12/18. About 11 days later, patient develops fever, confusion, code stroke is called, MRI with contrast. It doesn't show a whole lot, sort of indeterminate process in the clival retroclival area with associated mass effect. Maybe some regional brainstem leptomeningeal enhancement. LP, though, is definitely abnormal, not highly abnormal, but definitely abnormal. Has 88 white blood cells with a polydifferential and a very low glucose. I could not find the protein on this one. Again, patient was started on antimicrobials, but the fevers persisted, the encephalopathy progressed. ID became re-involved about a week later, recommended starting IREZ empirically, but the next day, unfortunately, patient developed respiratory distress and hypotension, was intubated. Repeat LP at that time, again, had a very low glucose, now protein very high, now white cells much higher, still with a polydifferential, and now the AFB smear was positive. And 2 days later, the pleural fluid from the month before was reported as growing MTB. Fortunately, that patient expired. So in this case, I think if your initial clinical suspicion is for TB, go with your intuition. You know, the guy's pleural fluid findings were certainly suggestive of TB, and if no bacterial etiology is found or other things, you may want to go for tissue. Maybe you're going to do a pleural biopsy there or start empiric therapy. Like the other case, negative IGRA does not rule out TB disease. Now, this was a little bit unusual in that first LP. So early in the course of disease, TB meningitis may have a pretty normal appearing MRI and a polypredominance on CSF. So other suggestive factors were the very low glucose. And so if the bacterial cultures are negative or meningoencephalitis panel otherwise negative, you may want to think about TB or fungus because the two can look very much similar. And remember, this person was not only at epidemiologic risk for TB, but also gave a history of possible TB disease as a child. Okay, case number 3, and like I said, I just could not believe that these cases kept coming in. This was a young Hispanic female, no past medical history, came to the ER in March with fever and ear pain. She had had a recent ear infection that had been treated 2 weeks ago with antibiotics, and then developed fever, headache, decreased hearing, and difficulty ambulating for 1 day, was febrile and tachycardic, had a pretty normal looking white blood cell count, but a fairly significant anemia. Imaging, so CT had no acute intracranial pathology, but extensive left mastoid infusion. Got a very different picture on the MRI. So again, MRI a lot more sensitive when you're looking for some of these more subtle changes. Extensive abnormal signal intensity with diffusion restriction of the bilateral thalami, midbrain, and pons. Extensive leptomeningeal enhancement, not picked up on the CT scan. A small ring-enhancing lesion suggestive of an abscess, and extensive abnormality of the mastoid air cells. LP, highly abnormal, over 1,000 white cells, 71% PMNs, glucose 17, protein 206, gram stain negative. But remember, this patient had some oral antibiotics in the past. Not sure if that's sufficient to kind of sterilize things, but obviously a concern. So she started on broad spectrum antimicrobials, and IgRA comes back indeterminate. So here we have that mitogen really low, 0.10. But interestingly, the reaction to the TB antigens was actually higher than it was to the mitogen. I've seen that a couple of times in people who are really sick with TB. So a week after admission, she has a neurologic deterioration. CT is showing now some thalamic infarcts, hydrocephalus. She has an external ventricular drain placed and is intubated. So the CSF from the EVD now looks a lot better, only 5 white cells. But remember, this is above the level of inflammation. So it's really not, is the patient really getting better? No, clinically, she's getting worse, right? So don't be misled by these findings. On that day, her HIV came back positive with a very low CD4 count. So now that opens up a whole bunch of other differentials, right? At that point, they added empiric ambisome for fungal infections. 2 days later, CT head is worse, brain death confirmed. Precarious from 2 days before, returns positive for HSV and MTB. And so they start TB meds and acyclovir, but patient expired. So this one was not reported to us initially. We found out about it a couple of weeks later when the MTB grew from the CSF at the end of the month. So this one is really tough, right? I mean, it's just taking you down the garden path that this is a bacterial mastoiditis that extends intracranially, an acute process, severe process. But remember that you can see a polydifferential early in TB meningitis. And when your gram stain and bacterial antigens and cultures are all negative, you got to be thinking, well, what else could be causing this? Remember that TB can cause middle ear infection with extension to the mastoid and brain. I've actually seen that a number of times. It used to be much more common in the past. And when you have these infarcts suggestive of vasculitis, that's something else that's common in TB. So again, don't be dissuaded by that normal looking EVD fluid. It's not telling you the patient's getting better. And if you think of fungal, think of TB as well. This patient was at epidemiologic risk for TB and had HIV, which is one of the strongest risk factors for TB disease. Okay, last case of these 4. 60-year-old Korean female, past medical history, hypertension, hyperlipidemia, tinnitus, came to the hospital late April with blurred vision of the right eye, a drooping eyelid, headache, and dizziness. Labs were normal except for low potassium. Her head CT, CT perfusion, CT angio, all supposedly normal, chest x-ray normal. 2 days later, though, they are noting proptosis of the right eye, so they do MRIs. And that first MRI was read as normal. MRI venogram, however, showed some decreased flow and signal enhancement within the right transverse sinus and the sigmoid sinus. LP around that time showed a white count of 218 with 65% lymphs, protein 120, glucose 34, but again, AFB stain negative. So about a week later, Patient develops respiratory failure, is intubated. She undergoes a rapid, severe neurologic deterioration, develops diabetes insipidus, is comatose with fixed pupils. By this time, MRI is showing all the changes suggestive of cerebral edema. So her brain is just swelling up. MRI showed severe narrowing of bilateral M1 segments. They felt possibly from the cerebral edema. Meningoencephalitis panel negative. EVD is placed due to the hydrocephalus. So it wasn't until 5/9, so a full almost 3 weeks into this process, that now the MRI is starting to show something more, or certainly hydrocephalus can occur with TB cerebritis, but now we're starting to get some meningeal changes here, most pronounced along the basal cisterns and anterior surface of the brainstem. A note in the chart 2 days later said the TB gold was pending, but irrelevant since the CSF MTB PCR was negative, the CSF AFB culture was negative to date, and Carius for TB was negative. Also noted CSF now normal, which is not consistent with meningitis. The quantiferon, by the way, did return indeterminate due to a low mitogen, 0.19, and several days later, patient confirmed brain death, expires, and the CSF sample grows TB about a month later, or a month after it was drawn. So this is another really difficult case. This was not, jumping out to people initially, but remember, this patient had epidemiologic risk. That initial CSF was certainly suggestive with the lymphocytic differential, with the low glucose. Negative AFB stains and PCR don't rule it out. And the culture, unfortunately, can take weeks before it's positive. So just because it's negative within the first week or two doesn't mean anything. There was no basilar enhancement initially, but really had more of a vasculitic picture initially, actually involving the venous sinuses at first, and then the arteries later with multiple strokes. Remember that the negative IgA does not rule out TB. And interestingly, this Carius also came back negative. Remember that Carius is a blood test of cell-free DNA for TB. I don't know what the data is in isolated disease in the CNS, but obviously it was negative in this case. And finally, don't be misled by that improving or normalizing EVD fluid. It's not reflecting what's going on below. So these were a very unfortunate series of cases, but just to kind of summarize and drive home the point, IgA in these 4 cases, none of them were positive. 2 were flat out negative with no response. 2 were indeterminate. Initial CSF AFB for those that were sent were all negative. The PCR on the 2 that I know were sent were negative. Initial CSF differential of the white blood cells, 2 were lymphocytic, but 2 were more of a poly predominance. Initial glucose was all less than 40, 3 of them less than 20, and proteins were all high. And it took from 3 to 8 weeks for the TB to grow out of the CSF. So we really need to maintain a high level of suspicion. And I'm happy to say that subsequent to these 4 cases, we've actually had 2 more recently in which the diagnosis was picked up much earlier. And they were not highly symptomatic. So this first one was a young Filipino man with knee TB who got admitted to the hospital in May for an anxiety attack 1 week after starting treatment as an outpatient. He complained of mild headaches and disorientation, but they resolved quickly. He was neurologically normal in the ER. But they did a CT scan of the lungs because thinking this anxiety attack may have been a PE, and it showed a miliary pattern, which wasn't appreciated on his chest x-ray. And we had been trying to get the patient in for sputums, but because of his knee pain, he could never come in. So they did one there, and it was 1+ AFB and PCR positive. So now we have not only knee TB, but also lung TB, so disseminated. Again, CT had negative, but MRI, multiple small foci of both cortical and subcortical T2 possible embolic lesions. So again, shows you how CT heads are not helpful when you're looking at CNS TB. And his CSF was impressive. I mean, glucose of less than 20, protein 324, white count 56. Again, a polydifferential because this is relatively new. Caught early, this guy is fortunately doing very well. And another one, again, just a month after that, 46-year-old Vietnamese male, classic TB symptoms, diagnosed with pulmonary and GI TB in the hospital. The ID doc who I was communicating with said, the guy's complaining of some headaches. I'm like, let's work him up. And so he did. He got a head CT, again, negative. And in this case, the MRI with contrast was also negative. But the ID doc did the right thing, still said, let's still LP him. And look at that LP. glucose 29, protein 130, 616 white cells with, again, polydifferential. So very early TB meningitis picked up in an otherwise healthy guy who had a negative MRI. So the meningitis encephalitis panel, bacterial culture is all negative. So we need to have a higher level of suspicion, even if CNS symptoms are mild, really mostly in patients with disseminated disease with multiple areas involvement and spinal cases that have had a long delay in diagnosis. But definitely any TB patient who has significant CNS symptoms should be worked up for CNS TB. So once you make the diagnosis or suspected diagnosis of CNS TB, you always want to order an MR angiogram or MRA of the brain, because that vascular involvement is what leads to a lot of morbidity, a lot of strokes. And like my patient that I discussed initially, her steroids were tapered off after 8 weeks, which is what the guidelines say. But she really needed to be on. We put her back on steroids eventually, but she had such a horrible paradoxical reaction. It was just kind of too little, too late. So we want to do definitely a longer and slower taper of steroids in people that have significant vascular involvement. Consider aspirin as a stroke prevention. There's not much data on that. Some have suggested high dose aspirin, but that brings some concomitant bleeding risks. And remember that if patient has CNS TB and they show clinical deterioration, you want to repeat that, because you may see new lesions or flaring of lesions or new strokes. So you want to follow up with that. So as I mentioned earlier, the treatment of TB has changed a lot, or TB meningitis has changed a lot in the last 10 to 15 years. So I'm going to talk about what is now recommended. Now, you're not going to find these in the guidelines. You go to the TB guidelines, it's going to say you use the standard medications, right? You use these INH, RIF, ethambutol, PZA at these doses. So there will probably never be guidelines that state with these things I'm going to be telling you about, because to change the guidelines, it would need multiple large controlled studies, which just are not going to happen, these days. So just one tip about these doses for standard routine TB, always dose the EMB and PZA based on ideal body weight, not the actual body weight. We do have a lot of patients who are obese, and if you give them those high dose of PZA, they're going to be upset. So I always ask for a height and weight on all of our hospitalized patients and adjust down if need be. Also for kidney failure or impaired renal function, we're going to want to increase the interval on EMB and PZA. So this rifampin 10 milligrams per kilogram was derived as the minimum effective dose of rifampin, with a max being 600. So back in the 70s, we did not have the obesity problem that we have now. It's clear that 600 is just not enough for many patients. And this minimum effective dose was agreed upon because at that time, rifampin was very expensive. It is now cheaper. It's easier to, it's kind of more economically feasible to give higher doses. So many feel we should really be rethinking that. So although efficacy data is limited, the current practice, if you call CDPH or other experts on TB meningitis, is to intensify treatment for CNS TB because it's such a horrible disease with a high mortality, at least 30% in our experience in the last 2 years, 50%, and because there's significant issues with drug penetration. Importantly, rifampin, which is kind of our keystone drug for TB, really does not penetrate the blood-brain barrier well. The concentrations in CSF are only about 10 to 20% of those in plasma, and EMB does not penetrate at all. So if you started someone on the standard IREZ, and let's say about 10% of our cases are INH resistant. So if it's INH resistant, that's not going to work. The ethambutol is not getting in at all, and the rifampin is going to be about 10 to 20% of the level in plasma. So you're effectively on monotherapy. So for these reasons, we always are going to now, if you call us and let us know about the patient, or we're going to recommend increased dose of RIF up to 30 milligrams per kilogram, which sounds high, but it's remember that RIF has concentration-dependent pharmacokinetics. So the higher it is, the more quickly, the more efficiently it's going to kill bugs. You can give it IV. Actually, we recommend IV in those who are pretty sick. That dose can be half of the oral dose. So you may start off with RIF 15 to 20 milligrams per kilogram IV, and then transition to PO as patients getting ready to leave the hospital. And we also recommend adding fluoroquinolones, usually levofloxacin. as a fourth agent that has good CNS penetration. The dose is 500 if your patient's less than 100 pounds, 750 if they're over 100 pounds. You might consider linezolid if you want to have a fifth agent on board. That is just a daily dose instead of the BID for most other infections. And then you're going to want to blast her away with high dose steroids, 0.3 to 0.4 milligrams per kilogram, dexamethasone, IV divided Q12. And remember, if that MRA comes back with a lot of vasculitis, you do not want to taper it quickly, as is discussed in the guidelines. I'm becoming to realize much more how much the immune system plays a role in the morbidity due to TB meningitis. It's a highly inflammatory condition, and once we have the patient on the drugs, we want to decrease that inflammation as much as possible. So I was kind of surprised to see, I'm way behind in my journals, but I was actually looking at the recent clinical infectious disease editions, and the one from July 15th of this year actually had 3 articles in relation to high dose RIF. So there was one that was a meta-analysis of the efficacy of higher dose RIF for TB, and their conclusion was that a dose between 25 and 35 milligrams per kilogram is optimal, which kind of goes along with that 30 milligrams per kilogram. The data they had on mortality in TB meningitis, unfortunately, did not lower mortality, but the vast majority of that result came from a single study done with over 400 subjects, in which they gave only 15 milligrams per kilogram, which is really not high enough, probably not that much different than 10 milligrams per kilogram, not enough to maybe see an effect. And 43% of the study subjects were HIV positive. So again, it's going to be impossible to have good controlled studies to kind of show that this works. But the accompanying editorial suggests that we really need to rethink that approach, that the minimum effective is really just not good enough. So further things to do for TB meningitis are we're going to want to prolong treatment at least 9 months, if not 12 months for really horrible cases. Although I must say that patients get pretty darn tired of taking the medicines, and sometimes it's hard to convince them to go those extra 3 months. You do want to continue the PZA as long as possible. PZA is really a key drug in TB meningitis, as long as they're tolerating it, not developing a hepatitis or having nausea, vomiting, and weight loss. If that happens, you can DC it at 2 months. You want to check therapeutic drug monitoring for INH to make sure that the level's adequate, and most importantly for the rifampin, and we're looking for a target of about 24 or higher. So as I said, many cannot tolerate all these meds for long. They're really most important in the first, the initial phases of treatment. But over time, if patients are complaining or having issues, you can DC additional meds. Certainly the first one I'd probably discontinue would be linezolid, then maybe DC the PZA. But again, if you can get them more than 2 months better, maybe you reduce the dose of RIF, maybe you have to DC the levofloxacin. And again, slow taper over months. So my patient JA was on steroids for the rest of her life. In those who have tuberculosis or vasculitis, and watch for those new neuroscience. We had one little kiddo, a baby that had, tuberculosis, that as they started tapering the steroids, he would flare. They would need to increase the doses again. So finally, reporting all active or suspect TB patients being discharged from the hospital or transferred to another healthcare facility by law in California have to be reported to TB control and get our approval. We ask that you do that, and the law states that it should be done within 1 day of diagnosis. Now, like I said, it doesn't have to be confirmed. If you're suspecting it's TB, report. Please don't wait until the patient is ready for discharge, because there's stuff we need to do from our end. We need to confirm the address. We need to check and see if there's any high-risk people living in that household. We want to start the household contact investigation. We want to make sure that patient is, clinically stable to go home. So there's stuff we need to do. And if you ask us on the day you're planning to discharge, we're going to say no. How do you report? It's by submitting a confidential morbidity report, or CMR. So I have links here to several local jurisdictions. You're supposed to report to the jurisdiction where the patient lives, but that's tough. So really just send us, if you're Orange County Hospital, send us a CMR on our own CMR, and we'll forward it to wherever they live. But it just helps to have all that information that we ask on the CMR. So TB is certainly not easy, but we are here to help. We have a hospital liaison who I think is on vacation right now, but someone should be answering her line. We also always have an on-duty nurse that is manned from 8 to 5. You're welcome to call us with any questions, with any issues. I'm very fortunate to have Dr. Kui Win, who is probably one of the most experienced TB clinicians in the state. He's been doing this over 25 years, so either he or I would be available to talk to you. Now, for Orange County hospitals only, please. I know there's a lot of people from other jurisdictions. We don't have the bandwidth to be talking about other jurisdiction cases, but feel free to give us a call and we can call you back. So, because for us, really, everything is tuberculosis. Although really not everything. Sometimes you're not sure, and sometimes we can look at that case and say, you know, we don't think it is. But most of the time, we're going to think it is. So in summary, TB or TB meningitis, CNS TB, has a high mortality and is challenging to both diagnose and treat. As you can see from those cases, 4 very different presentations, right? One more meningitic, one more vasculitic, one with a spread from the ear infection, and another vasculitic one. So you really have to think TB in patients who are at epidemiologic risk for TB, who have unexplained inflammatory neurologic conditions such as meningitis, meningoencephalitis, cerebritis, cerebral abscess, or vasculitis. So it's important to recognize those findings suggestive of it, because none of the tests are perfect, and to start treatment early to minimize the risk of morbidity and mortality. It's fine if you start and we end up finding it's something else and we can stop. Better to have started than to not start and the patient progresses. And then don't forget to report those TB suspects as soon as possible, ideally well before discharge planning is underway. So just to let you know, we do have a CD Health alert that you can sign up for Orange County clinicians, as well as a monthly county health officer newsletter. And with that, I would like to thank you for your attention. Hopefully you're paying attention. I can't see you all, how many are falling asleep. Yeah, but if you would like a copy of the slides, and I don't know that we can email all those out, but you can email us at pds@ocha.com, and hopefully a link to the recording of the lecture will be emailed to all participants. And actually, Angelito, if we do email the link, we can also send the slides as well. So happy to stop now and take questions from the chat box, or if you have one that's easier to just speak, you can raise your hand and we can unmute you.
Thanks, Dr. Calve, for that very insightful presentation. We do have several questions in the chat box. I don't know if you have access to it currently.
I do. Okay, so let me go back up to the beginning. So yes, a recording will be available. Got it. All right. Travel risk to high-risk countries for US born. It kind of, I think the cutoff point is a month. So if you've spent a month in a country with high prevalence of TB, then you should think about testing for TB. Can you review test results in the setting of non-tuberculous mycobacterial? Okay. So NTM disease, I don't know if you're asking about in the lung, but IgRA should not react. Now, there are some NTMs where the IgA could react, but normally if we see a positive IgRA in a person with documented TB disease, and we think they probably also have at least latent infection, if not active disease. So with folks with pulmonary infection who have positive smears, if you have 2 negative IgRAs, that kind of tells you that probably TB is not causing those positive smears. You would still want to wait until cultures are final to be absolutely sure. But you could go ahead and start treating NTM, and then also at some point treat latent TB, which if you're going to treat the NTM with rifabutin, that's going to cover latent TB infection as well. Okay, for these cases, since pulmonary smears are negative, are we confident that there is technically any exposure to, good question. Yeah, so that's again, just the importance of doing adequate, induced smears if you can, just to make sure. But yes, if there is no pulmonary disease, then they are not, there's no exposure concern. Whenever we identify a suspected extrapulmonary case, though, we do request that you put them in respiratory isolation until you get those 3 smears, and ideally do 3 smears with 2 gnats just to kind of confirm. Yeah, so someone asked about the carious, would be very sensitive for TB. I don't have a lot of, we definitely can't order that test here in public health. It's way too expensive. I can tell you, we've seen, definitely made the diagnosis on Karius several times when patients had very unusual presentations. And when we treated them as TB, but this is the first one I've seen where the Karius test was negative and there was documented disease. Now, my thinking is, since this is a blood-based test, it seems like this disease was all in her CNS. Now, you'd think that still enough of it would kind of leak out. And I don't know what the lower level of detection of Karius is, for TB, but that one was definitely puzzling. But it just drives home the point that none of the tests are perfect. You don't completely rule out TB, even negative cultures. Did any of the patients have nuchal rigidity or meningismus on exam? Not that I saw. Now I'm just like looking at admission history and physicals. Sometimes they don't have the most detailed neurologic exam, but I didn't see anyone with significant meningismus noted in the chart. Okay, about testing for LTBI, I noticed a common practice of repeating the quantiferon, and if negative, no treatment. Even if the patient has positive risk factors, what are your thoughts about IgA variability? Yes, the IgA is an extremely variable test. I actually did a whole lecture, if anyone's interested in watching a whole lecture on this, when I first came back to TB control in Orange County, I did a lecture for our staff that kind of goes into the ins and outs of IgA. And my approach to it is, if I really think someone has TB, like say we see a lot of immigrants, if that chest x-ray looks all the world for TB and the IgA is negative, but there's some reactivity there, like the 0.15 to 0.25, I'm going to call it TB and I'm going to offer them treatment. So it kind of depends on the pretest probability and what the chest x-ray looks like. But we will always repeat an IgA, and immigrants are now getting IgAs overseas. I don't know how good those labs are, so we're always repeating them. And we do see many who were negative overseas testing positive here. So again, it goes back to your clinical suspicion. Of course, your clinical suspicion is not always going to convince a patient to take LTBI treatment. All right. Also, since in California we're testing more, should we be treating more? Yes, absolutely. So the new law, and Angelita, remind me, is it 1232, AB 1232?
AB 2132.
Oh God, I'm so
Close.
dyslexic. 2132 is now requiring that all primary care providers should do a risk screen for TB. So certain risk factors, and one of the most common ones is probably foreign birth, that those people should be tested for TB. And really, IgA is the ideal test to do. And if they turn positive, then they should be treated. Thank you for that introduction, Dr. Andrade, because that allows me to say we are not going to see decreased cases unless we start treating more LTBI, because we have this large pool of immigrants who are getting older, who are getting more immunocompromised, and are going to reactivate their TB unless we nip it in the bud and treat them when they have latent disease. Yeah, so we can see high nils in people that are sick, and I always get concerned when the nil is really high. I don't think it's all that of a good of a test when the nil is really high. Yeah, and some labs are going to report the gross TB1 and TB2 responses. Some of them are going to report it TB1 and TB2 minus nil, but they usually will give you the actual nil value as well. And when do I get concerned with a high nil? Initially when I have experience with the IgA from like day one back in 2006, and we saw a lot of variability, a lot of false positives with high nils. Back then, the nil, if it was greater than 0.7, it was considered indeterminate. On the next generation of the IgA, they just increased the nil to like 7. So if you're getting a nil of like over 1, 2, or 3, that's not a great test. I'd probably repeat it. Is rifabutin an alternative for CNS TB? Good question. I think we did talk about that, and I just don't think there's a lot of data. If the patient has some significant reaction to rifampin, am I going to try them on rifabutin? Absolutely, because I think some rifamycin is better than none, but I just don't think it's really been studied. Okay, how to decide airborne precautions for quant negative sputum? I don't know, NGT, PCR negative, and suspected TB, tuberculoma. So if chest X-ray is looking normal, if you have 3 good induced sputums, and I know it's hard to get, this is a big issue, right? Patients who are out of it, who are demented, who are very frail, cannot produce sputum. And we don't have a good way to really assess. But let's say your patient is able to produce good sputum. You have 3 smears that are negative. You got 2 negative gnats in the sputum. Chest x-ray looking pretty normal, not suspicious for TB. But you think they have TB someplace else, you can take them out of airborne isolation. There are other for post-infectious inflammatory and other infections. Yeah, other alternatives. Yes, Dr. Andrade, there is data actually for using TNF alpha inhibitors in CNS TB where the immune response sort of worsens even on steroids. I think Dr. Reed, if she's still on, might be able to address that. But we almost got that point with my patient JA. But fortunately, so far, other ones who at least have survived have done okay with steroids alone. Yes, we will be sharing the slide deck. If you don't get it from us, though, in the next couple of days, please shoot us an email at that pds@ochca.com just to be sure. Yeah, there's just so much variability. So this question is about educate me more about quantiferin gold indeterminate result. I was told in the past that mixing the sample is insufficient. One could get an indeterminate result, and the thing to do is to repeat the test. Is this not true? No, it is true. I mean, this is a test that can be like positive 1 hour and negative the next when you're near that borderline. I call that a wobbler. So all kinds of things can happen. It's extremely variable. If you want to listen to my lecture and get all the details, but yes, if you get an indeterminate result, you want to repeat that. Now, if the indeterminate result is due to very low mitogen and that person has severe immunocompromise, you're probably not going to get a valid result. It may come back indeterminate again. And unfortunately, I don't have anything to say about that. For rifampin dose up to 30 mil, is it referring to rifampin up to 30 milligrams per kilogram? Yeah, up to or even more. I mean, there are many people or some people that have given even higher doses of that based on therapeutic drug monitoring. If it's not adequate, they may go up. So our target is kind of 30 milligrams per kilogram, maybe 35. And thank you, Dr. Lori Thrupp, if you're on. He is the one that spearheaded an effort. Even though there's no guidance, no national guidelines, the California TB Controllers Association did accept a kind of paper agreeing or suggesting that we should be doing this in CNS TB cases.
I believe Dr. Thrupp was trying to raise his hand. Dr. Thrupp, if you're still on, go ahead. I've unmuted you if you want to say something, but go ahead and continue, Dr. Calve.
I was just going to make the point that the low-hanging fruit for screening in primary care clinics are the foreign-born diabetics. That's the highest take rate that you'll get for LTBI and for treatment of LTBI.
Definitely. But I think just not only diabetics, just any foreign-born, but yes. Okay, sorry, let's see. What is a protocol for patients on B-cell depletion who are identified as quant positive or indeterminate? Quant positive, I would treat. Indeterminate, tough to say. You can repeat it because this is more of a T-cell reaction thing, but if it's again indeterminate, it's hard to say. If skin test is read as positive but quantiferin is negative, would the QFT be more accurate? Oh, good question. Kind of depends. I think size matters. So it depends on how positive the skin test was. If it's like borderline 10 millimeters, and the quantiferin is absolutely negative, like 0.0, then I'd say quant is more accurate. But look at those quantitative values. If the quantiferin is 0.34, that is almost positive, and that person has it. If it's like 0.30, 0.25, then I might say okay, and the skin test is very positive, and I'd say okay, it is. It's hard. Most people just look at the result and say okay, negative is negative. The person doesn't have. Look at the quantitative results. Let's see. Good. Yeah, I don't. For this question about the taper, nothing that I can talk about right now. Basically, we do go down kind of slowly, decrease down. I don't know that I'd do that quick because it's over 8 weeks. No, I extend to months, more than 2 months. So do it more slowly, maybe instead of over a week, every 2 weeks, you're going to decrease in the dose. And then once you get to a certain level of dexamethasone, you switch over to prednisone, which then allows you more, smaller gradations of decrease. But I had a patient with pretty rip-roaring TB meningitis, multiple strokes, 40-ish year old Hispanic female. I think I treated her with steroids for 6 to 7 months. Is there a role for repeat LP in general to evaluate treatment response in these concerning cases? Yeah, possibly, because if your initial thing is not clear and the patient, all the bacterial things are negative, or meningoencephalitis panel is not negative, but I would still look at that initial one. So a second LP may be helpful, but I'd also just start thinking more of TB, and if the person's at risk, think about starting medicines. Yeah. Oh, good. Thank you, Dr. Reed. She said, yes, there are steroid refractory cases where TNF alpha inhibitors, JAK inhibitors, and other immunomodulators have been used. All right, I think that is it. Thank you all for hanging in a couple minutes over. Appreciate it. Just send us any questions and we'll be getting you the link and the slides hopefully soon.
Yes, and a few final reminders to everyone. The evaluation survey will be emailed to you in the coming days. And please complete the survey within 48 hours to receive your CME or CE credit link. And a recording of today's webinar will also be shared with all attendees. On behalf of the Pulmonary Disease Services of the Orange County Healthcare Agency, thank you again for your time, your questions, and your continued work in protecting community health. We look forward to connecting with you at future trainings and webinars. Have a good rest of your day. Thank you.